So, yes, is the voice audible to everyone?
Yes, sir, it's audible.
Second. So, yeah, Alvin, I think we can start. So, visibility or audibility, correct, guys? Everyone visible? Is it audible and visible? So, today we'll be discussing about the role of the clinical pharmacist in monitoring of cardiac medication. So now, before we start, I just want to introduce myself, okay, and why we have planned this out. My name is Dr. Joseph Sabuwala, and I'm the clinical pharmacologist working in Aware Global Hospital, LB Nagar. So, why we selected this topic? Because we have been seeing everyone celebrating Cardiac Day. Okay, we have been seeing them celebrating Cardiac Day through various other means. But as clinical pharmacists, what do you think we should be equipped of before we celebrate this, or before we say that we are confident enough in our field? So before we start today, I would just like to, share few statistics that are there. So healthcare medication errors have caused almost 30% of damage to the patient. And mind you, these 30% are revertible cases. So this can be, you know, role played by clinical pharmacists to avoid this. Okay, so they play a pivotal role in reverting these medication error cases, and there are various other roles a clinical pharmacist plays. Okay, so the why cardiac department. I hope many of you have interest in cardiac area. Many 50s have done many projects in that area, right? So we'll be discuss. So basically, in this 1 hour, it would be difficult for us to discuss about all the cardiac medication. But I will make sure that I discuss the most important cardiac medication along with the pharmacokinetics and ADR. So can anyone tell me the first class of the major cardiac medication that I used? First is
Antiplatelets.
diuretics. That is the most important. Antiplatelets, yes. First, we'll discuss about diuretics because diuretics are also used in other cardiac conditions in heart failure, in hypertension. Okay. So we'll be discussing about diuretics today. Then we'll be discussing about beta blockers. Then we'll be discussing about alpha blockers. Then we'll be discussing about ACE and ARBs. So I would just like to say that this discussion would not be in depth trying to teach you what is there. But today I will be focusing on areas that a clinical pharmacist can work to rationalize of the therapy for the using of these drugs. So this discussing just these four groups and also calcium channel blockers we'll discuss. Okay. Discussing these five groups, I'll show how a clinical pharmacist can involve in the therapy for these patients, and also you can practically get involved in the management of the patient. So this would be just an blueprint for you guys to concentrate more in-depth teaching of these drugs. Okay. So after this discussion, in the end, I will be having a session where I'll share which areas we can focus as a clinical pharmacist, checking the indent of the drug, checking the combination of the drug, checking what drug has to be given in cardiac medication, and monitoring of those drugs. So that would be the second part of today's session. And in the end, we'll end it with Q&A. Okay? Whatever question and answers that you guys have, we'll be doing it. So diuretics में there are many diuretics. There are thiazide diuretic, loop diuretics, osmotic diuretics, potassium sparing diuretics. Most commonly used in hypertension. Can anyone tell me what are the most commonly used type of the diuretic in hypertension? Tell me what is
Chlorothiazide,
the it is thiazide
hydrochlorothiazide.
diuretic. Okay? That is what fluorothiazide, fluorothalidone. Thiazide diuretics is the most commonly used. Next, for patients who have heart failure, patients where they require higher diuresis, okay, in those patients we use loop diuretic. And these diuretics usually will cause loss of electrolytes. Okay? So in that, potassium is a critical electrolyte along with sodium and all. So potassium, we need to retain potassium. That is why potassium sparing diuretics are also there. So I will not be again. See, telling. I'll be telling about the pharmacology, kinetics of these drugs briefly, but I will stress on the points where you, as a clinical pharmacist, have to focus on. Right, guys? I'll be focusing that. So now let's get back to the thiazide diuretics. Okay. So can anyone tell me the examples of thiazide diuretics? One is chlorothiazide. Other one is hydrochlorothiazide. So remember, thiazide diuretics usually work on which part? It works on the DCT, distal convoluted tubule. So they will, prevent the reabsorption of the water by affecting the sodium. Sodium is a friend of water. So whenever there is sodium, water will move along with it. So patient will automatically have reduced sodium level, reduce potassium level. Most important thing to remember as a clinical pharmacist is thiazide diuretics will indirectly increase the uric acid level along with loop diuretics. Loop diuretics effect is superior, but thiazide diuretics cause mild hyperuricemia. Okay. Along with that, thiazide diuretics also increase the calcium level. They also cause hypercalcemia, hyperuricemia. So what happens is whenever the patients are on thiazide diuretics, it is most important to remember the creatinine clearance. So if the creatinine clearance is less than 30, usually thiazide diuretics should be avoided. ये most important है. You should calculate the creatine clearance in patients who are on diuretics, and there is one diuretic that is, exceptional, thiazide diuretics, that can be also used up till 10 creatine clearance. Can anyone tell me the name of that diuretic? Diuretic that has to be used even when the creatine clearance is less than 30. Up till 10, it can
Metolazone.
be used. Very good. Metalazone is the diuretic. Remember this point, very important. Metalazone and Zyton or उसका ब्रांड नेम इज जाइटेनिक्स। सो ये क्लिनिकल फार्मासिस्ट पॉइंट ही था जो मैंने बोला था, ये दैट दिस कैन बी यूज फॉर लोअर क्रिएटिन क्लियरेंस आल्सो. Now, next important thing is you might see patients on loop diuretics and thiazide diuretics. Is it true or not? Patients usually heart failure, pulmonary edema, you will see them on both the drugs. Have you seen it or not, guys? Have you seen it in your hospital setting?
Yes, sir.
Yes. So what happens is usually many of times I have seen they are given both at the same time, 2 p.m. and 8 a.m. 8 a.m. it is better to give loop diuretics. 2 p.m. better to give thiazide diuretics because by the time the filtrates from the glomerulus comes to comes to loop of Henle, लूप डायरेटिक्स यहाँ पे एक्ट करेंगे, मॉर्निंग में आप देंगे. देन द फ्लूइड कम्स टिल डीसीटी, इट वुड टेक सम टाइम, so that you should give at spacing. So first diuresis will happen here, second diuresis will happen here. So this timing is also very important of thiazide diuretics along with loop diuretics. This is known as effective diuresis. Timing is very important in this patient. So it is important to remember that chlorothiazide has T half of more than 24 hours when compared to hydrochlorothiazide. इसलिए इसका effect is more. Clinical pharmacist point. Remember, hydrochlorothiazide usually is given at the dose of 12.5 mg to 25 mg. More than this dose has been shown to cause cardiac mortality. They have increased the cardiac mortality. That is the reason why, remember, safe doses of these drugs also. Right? So this was loop diuretics. I hope you got many of the important points that I have told you. Right? So let's discuss about loop diuretic. We have discussed thiazide diuretic. Can anyone tell me the examples of loop diuretic?
Furosemide,
Furosemide.
Furosemide. Next,
torsemide,
torsemide. So these drug usually acts on the sodium potassium 2 chloride channel, ठीक है, that is present in the loop of the Henle. So ये act करके it inhibits this, so that causes inhibition of the reabsorption of water, sodium and water molecules, that acts as a symport, ठीक है. And remember, the same transporter is used for uric acid transportation. So, if it is used by sodium, then this uric acid will increase in the filtrate, causing hyperuricemia. So, usually patients with gout should be taken care while on diuretics. Usually, diuretics is indicated, then only given. You cannot stop diuretics saying that it causes hyperuricemia and it should not be used in gout. No, that is not right. Because patients with cor pulmonale, patients with pulmonary edema, that causes respiratory failure due to water accumulation. In those conditions, loop diuretics are the choice of the drug because it causes effective diuresis. So now important to remember, these are not used for hypertension. These are commonly given in patients who are having fluid accumulation either in heart failure or in renal failure or in patients having cor pulmonale due to COPD. Okay. So most important thing to remember as a clinical pharmacist in these is वो तो मालूम ही है आपको कि it decreases sodium, decreases potassium, it also decreases calcium. Thiazide diuretics increases, this decreases, and this increases the uric acid level. So, as clinical pharmacists, you should remember this loop diuretics are sulfa drugs. Thiazide and loop are sulfa drugs. Usually, sulfur drugs have allergy. Second thing is these drugs might also cause lupus-like reaction, lupus-like effect. Usually, all the sulfur drugs causes lupus-like effect. Now, it is important that you see in a hospital setup furosemide and torsemide differentiation. So, furosemide, you should remember this as a clinical pharmacist. Furosemide rate of absorption is variable. Okay, it is variable. You cannot say that this drug is this much effective, this can be absorbed that much. But torsemide bioavailability is better when compared to furosemide. Then why do you think that furosemide is being used over torsemide in hospital setup? You should answer with a good point in it. Why do you think it is being used in hospital?
IV formulation.
No, torsemide is also available in IV formulation.
It acts rapidly.
No,
Half life is more.
okay, almost not. That is not the major factor. The major factor is cost effective. Torsemide is comparatively expensive when compared to furosemide. And do you think diuretics is used only once or twice in heart failure patients or patients with fluid loads? It is used for a good amount of period of time. And in those patients, we will not see about the absorption, but we will see about the compliance of the drug, in which furosemide will win over torsemide. So patients who are affordable and all, you can torsemide is a better option when compared to furosemide. So let's discuss about beta blockers. Okay. Can anyone tell me where are the beta receptors present in our body? Three types of receptors. First we'll discuss, then we'll discuss the drug. Beta 1 is present where?
Heart and JG cell. Heart.
Beta 1 is present in JG cells. Heart. Beta 2 is present in lungs and blood vessels. Very good. Beta 3, adipose tissue. So, firstly, we'll be focusing on beta 1 cells and here beta 2 also. So, tell me the beta non selective drug first.
Propanolol.
Propanolol, very good. Next is atenolol, nadolol और बोलिए कौन से metoprolol,
Bisoprolol.
bisoprolol. Carvedilol is not a pure beta blocker. Okay. So remember, uh, JG cells is responsible for secreting renin. Renin will cause angiotensin, angiotensinogen ACE 1 and 2 that you already know. We'll not discuss those points. So here in beta blockers, there are three important things that a clinical pharmacist should know. Okay. Firstly, you should know the kinetics of these beta blockers. So there are two types of beta blockers. One is hydrophilic. We'll just erase a part of it, okay, so that it is clear for you all. One is hydrophilic, other one will be
Lipophil.
hydrophobic. So can anyone tell me what are the hydrophobic type of the beta blockers? Labetalol, labetalol, atenolol, nodalol. So all these are hydrophobic. Hydrophilic are the rest of the drug. Usually, hydrophobic drugs have better anti-arrhythmic activity when compared to hydrophilic drug. Anti-arrhythmic activity of hydrophobic drugs are better when compared to hydrophilic drug. Most important point you should know. So now it is important to know in these beta blockers, okay, there is one drug that also causes nitric oxide release that causes NO vasodilation. Can anyone tell me? It is beneficial in patients with peripheral PAD, peripheral arterial disease, or patients of diabetes, जो कि diabetic foot में usually you see claudication रहता those patients में. What is the beta blocker that is preferred over those patients? Can anyone tell me name of the drug? It starts with B. B, B. Beta blocker with B.
Bisoprolol.
Bisoprolol. Very good. So it is bisoprolol. It causes nitric oxide release. Okay. So beta blockers are used for heart rate, elevated heart rate. It might cause QTC prolongation. Remember, beta blockers. It is used to treat tachycardia, sinus tachycardia. Okay. Then it is used for management of what? It is also used for hypertension. It is also used for increased sympathetic response in our body. Then what else, guys? What else it is used for?
Migraine.
No, not migraine. Mostly it is used for headache. Sodium valproate is preferred over propanolol. Okay, coming to this point, propanolol can easily pass through the BBB. That is why it is used for some type of headache, not specifically migraine, and it is also used for treatment of essential tremors, propanolol. This, as a clinical pharmacist, it is good to know the indications of the drug. Now, most important point used when patients, diabetic patients are on beta blockers. Usually, whenever the patient is having hypoglycemia, they will have any signs and symptoms. One, when patients are on beta blockers, those hypoglycemic symptoms are usually masked. So, patients who are diabetic, okay, patient who are diabetic and they have a history of having hypoglycemic attacks, it is always better to keep monitoring the sugar levels while on beta blockers, or to avoid beta blockers is a better choice, because whenever the patient is in hypoglycemia, there is always a trigger signs and symptoms that is masked when patients are on beta blockers. Next thing, beta blocker activates the sympathetic, they inhibit the sympathetic activity. So do you think it can be stopped suddenly, or it should be tapered over the time? What do you think?
Should be tapered, sir.
It should be tapered. Most important, beta blockers should be tapered over time. Next thing, beta blockers are also responsible for increasing triglyceride level and increasing LDL or decreasing HDL level. This a point I think you should know. It increases triglyceride, decreases HDL, and alpha blockers do the opposite. They increase the HDL levels and decrease the LDL level of the patient. So these are the few pearls that you should remember in a working setup about the these drugs. Very important. Few points that I've shown you. You, as a clinical pharmacist, it is very important to focus on those points when the patient is on that therapy, because in the end, the safety lies again with the drug usage that is happening in the hospital, and that you can actively involve. So now, alpha blockers. Alpha blockers, how many receptors are there in alpha blockers? There are two receptors. Okay, one is alpha 1 and alpha 2. So, what type of alpha blockers I am discussing you about? Yes, what type of alpha blockers?
Alpha 1.
Think and tell. It is alpha 1. So, there is prazosin, doxazosin. So, most important thing to remember, patients on alpha blocker as a clinical pharmacist and with the designated role of medication safety that is given to you, what is the most important point to remember when patients are on alpha blockers?
First dose
Fast onset of
phenomena.
Very good.
First dose.
Syncopal effect or the first dose phenomena. Usually, patients on alpha blockers tend to have giddiness or syncope initial time. So that is the reason why they should be started in the night time. Okay, over a period of time that can be taken at the daytime also after using it for a while. So that is mostly elderly have a fall due to this syncopal effect that the patient has. So alpha blockers, syncopal effect or first dose effect is very important. Okay. So next important thing to remember in alpha blockers is that its effect on that of the cholesterol levels that we have already discussed. Okay, so remember this, and these are the strongest antihypertensive drugs that are used because these are usually used at the end for patients who are on CKD or patients who are hypertensive. You know, resistant hypertension or refractory hypertension. These are two different terms. Okay, this is not the same. Resistance hypertension and refractory based on the number of the drugs the patient are, it is classified. That we'll not discuss right now, but just read about it. So next is calcium channel blockers. Okay, so this is again a very important thing to remember. How many types of calcium channel blockers are there?
two types, dihydropyridines and non-dihydropyridines.
Very good. Dihydropyridines example,
Nifedipine.
nifedipine,
Amlodipine.
nicardipine, amlodipine, benidipine, clinidipine. So this last three drugs are most commonly used in patients. Okay. Uh, non-dihydropyridine,
Verapamil, diltiazem.
verapamil, and diltiazem. So remember, nifedipine. See, I'll give you bullet points. Okay, directly. I'll not discuss deeply how the drug works. Firstly, there are three channels: L, P, N. L channels are usually present in heart. P and N are present in neuronal area. Neuronal area. So they are responsible for this cardiac L cells. Usually, इसमें L channel activator is amlodipine. L and T is clinidipine. LTN is benidipine. Benidipine is a novel drug introduced recently in Japan. Recently, matlab it is a very good time now, and it is also used in many parts of Hyderabad hospitals also. Okay, so L calcium channel blocker. Calcium अंदर नहीं आने देता. That will prevent depolarization also. And calcium is responsible for binding to calmodulin, a secondary receptors, and this inhibition also happens. Okay, so that is how it will reduce the it will have a negative ionotropic effect on the heart, and also along with it, it will also reduce the blood pressure in patients. Usually, cardiac calcium channel blockers is used in patients with of higher age. ठीक है, higher age because RAS mechanism is not active. RAS mechanism is not the pathology in higher group. So calcium channel blockers is usually preferred in older age of people. So in this clinical pharmacist related point, amlodipine will cause pedal edema. That will not be caused by clinidipine and benidipine. Why should be your question. Okay, so जो artery, veins, venules, and capillaries. These are small capillaries. So when it causes dilation of that area, okay, when it is causing dilation of this area, it will cause increase in the peripheral compartment that causes leakage of fluid into that and causes swelling. But clinidipine also acts on N channel and it dilates this area as well. So both area dilate होने से क्या होता? There is no escape of fluid in the external compartment, and that is why clinidipine and benidipine will not cause pedal edema, whereas amlodipine will cause pedal edema. Okay. So next is verapamil and diltiazem. Can you tell me about verapamil and diltiazem? These are commonly used for its negative ionotropic effect. Okay. And most important side effect of verapamil in hospital patients is constipation, headache and constipation. So now patient has heart failure. So will you give calcium channel blockers? Yes or no?
No.
So do
Heart
you think your
blockers.
answer is right? So there is a
I can
certain class of drug that can be given. Non-dihydropyridine can be given, but dihydropyridine should be not be given in those patients. Why? Means these patients will have upregulated sympathetic effect if it is reduced. मतलब rebound effect is seen, whereas that rebound effect is non-seen with non-dihydropyridine. That is why it can be used in those patients. I hope you guys understood.
Can you repeat it once?
Yeah, so dihydropyridines will have a rebound sympathetic effect, whereas non-dihydropyridines will not have a rebound sympathetic effect. अगर sympathetic effect आ गया, so what will happen? Its heart rate will increase. Heart rate will increase means what will happen? Workload on heart will increase. Workload on heart increases mean oxygen requirement of the heart will increase.
Increase.
So this is how patient should not be given dihydropyridines in heart failure. Next choice of drug are ACE and ARBs. So again, see, I'll not be teaching in detail the ecology and therapy, but I'll be giving you bullet points. So you all know JG cells, renin, angiotensinogen, ACE 1, 2, 2 से क्या होता? It activates two receptor, angiotensin 1, angiotensin 2. I hope you guys know. What does 1 do? Can anyone tell me? It causes vasoconstriction. It causes cardiac hypertrophy. It causes free radical damage of the cells. 2 causes opposite. It causes vasodilation, thus helping in hypertension. It causes reduced size or prevents cardiac hypertrophy, thus helping in ventricular remodeling. I hope you know ventricular remodeling kya hai. If you don't know, please say I'll explain. Next is reduces the free radical damage of the cell. So what is most preferable, 81 or 82? 82. So this ACE inhibitors will indirectly increase 82. Yes or no? No. It will not, cause formation of 81 also. But angiotensin receptor blocker will increase the level of 82 and decrease the level of 81. That is why they are preferred over ACE inhibitors. Okay. So ACE inhibitors most commonly, can tell me example what you see in hospital. Tell me. Don't tell me,
Ram,
fosinopril, lisinopril. What you see in hospital, most important you
Ram,
see is ramipril. Next,
Enalapril,
enalapril.
Enalapril.
So this is used in hypertensive urgency because it is available in IV formulation. So the consultants will ask you either for question sake, or they might also ask you why, which drug is available. So this is the drug. Ramipril, now they will ask you why it is preferred over other ACE inhibitors. So ramipril has a triphasic peak absorption or biphasic superior absorption. So there will be two times when there will be peak in the effect of the drug. That is the reason why ramipril is preferred over enalapril. Ramipril is preferred over other drugs. Okay. So ACE inhibitors, most important, you should know hyperkalemia. It also causes cough. It is contraindicated in pregnancy. This should be, a clinical pharmacist should know this. They are contraindicated in pregnancy. It causes hyperkalemia, cough, and it also has been shown to cause angioedema. We have seen this case, angioedema case due to ACE. Okay. So next, ARBs. Can anyone tell me the various types of ARBs that are there in the hospital?
Valsartan, Losartan,
Valsartan and sacubitril. This is again one interesting drug. This is a neprilysin inhibitor. Okay. This drug is also called as Enri. Okay. So why this drug is effective? There was a trial that was conducted that showed that these drug is helpful in patients with LV dysfunction or patients with reduced ejection fraction. So that is why you will see this drug Vimada. Okay. This is one most commonly used brand name for the drug. In the hospital, you will see patients with cardiac dysfunction. Next, patients on losartan. So one, see, this is again an interesting point that is there. A clinical pharmacist should know. I told you, right? Patients who are on loop diuretics, what will increase in their blood levels? What will increase?
uric acid.
Uric acid. So it has been shown that losartan has two benefits above other things. Okay. It is also shown to cause thromboxane inhibition. So this is preferable in patients who are on stroke, who had a history of stroke. So losartan is a better drug as a antihypertensive. And there is another thing is it also causes hypouricemia. So, as a clinical pharmacist, if you know these two pearls, you can, improvise the therapy or you can change the therapy while reducing the number of the drugs. You can increase the benefit that the patient has. I hope you did not know about these 2 points. Okay, these 2 points are new for you. Then remember, this is thromboxane inhibition, and also it causes hypouricemia. Next important thing is many of them don't know about the nephrotoxicity effect of ASNAR. Okay, today I'll discuss that. So patients who are having creatine more than 2 or increasing zero point 0.5 mg per dl in more than 20, in less than 24 hours, those patients who are on ACE and ARBs should be stopped. AKI made should not be used. Why? So in our body, physiologically, this is an efferent arteriole, this is an efferent arteriole. Can you observe the diameter of both? So the efferent arteriole diameter is more when compared to efferent. So this will help in preserving the, it will reduce the clear, it will preserve the, what it will do? It will increase
Blood
the
flow.
GFR, reduce its clearance. So that causes increased availability. But what will happen? ASARBs will dilate this. So it will cause easy loss. So that causes reduce in it the GFR. So that patients usually their GFR will drop. And most important as a clinical pharmacist to remember is there is higher pressure on these walls. Okay? So there will be proteinuria that would be causing in diabetic patient mostly. So ACE and ARBs by dilating reduces the pressure of the loss of the proteins in the urine, causing reduced proteinuria. So in diabetic proteinuria, ACE and ARBs are the choice of the drugs. So this was the basic pharmacology, kinetics, and the important pearls that a clinical pharmacist should remember in monitoring of the cardiac medication. So this is the theory part that I wanted to say. Now I'll be sharing the practical part that you should know when you are working in a hospital. So whenever you go on your rounds, usually patients in cardiac ward will be on ionotropes. So always involved in the calculation of its infusion rate. If you want, I will share the details of infusion calculations. We cannot do it right now due to limited time, but I have the calculation. I will share it in the group. Okay. This is the infusion calculation that has to be done for patients in ionotropes. Next thing, patients usually on diuretics will have combination along with potassium sparing diuretic. So whenever the patients are on these combination, you go to the patient drug, indent. You should physically check whether they are giving combination or not. Because sometimes what will happen that plus will be written furosemide plus. This plus means potassium sparing रहता है and sometimes mistakenly sisters indent only furosemide. Patient's potassium will be dropping. Consultant will see I have put potassium sparing, still it is not increasing. Why? Then unnecessary potassium chloride infusion will be given to the patient. So remember, you have to check for this. Okay. Next is patients who are on ACE and ARB. Always check the creatinine clearance of those patients. Okay. More than 2 should be avoided. Okay. And ACE and ARBs, you check their history. If they have cough, that is not pathophysiologically related to any disease. Again, this is important. Any patient having cough, you shouldn't stop ACE ARBs. If there is no explainable underlying pathophysiological condition, in those patients only, ACE and ARBs, there should be any suspicion of cough, then the use should be suspected. Okay. Next is in pregnancy. So whenever I go for rounds, I check for the inotropic calculation whether it is done properly or not. Whenever there is combination of the cardiac medications like diuretics, thiazide diuretics, and also creatinine clearance and thiazide diuretics, remember, or the timing of the drug I check whether there is any duplication of loop diuretics that is going on the patient. Okay? So you have to check these points. Then you have to check ACE, ARB. You have to check history of patient having hyperuricemia. Then if not losartan is there, can losartan be considered? If patient has history of stroke, can losartan be considered? Similarly, in ACE inhibitors, ramipril should be considered. patient having ventricular ejection, ventricular remodeling, then you can prefer, okay, potassium sparing and those drugs. So very important to remember. Okay. So now I think I have discussed a lot. Now I'd be happy to take questions from here on. If you guys have any question, please start asking because theory part I think I have told you a lot in this 50 minutes.
Between loop diuretics and thiazide diuretics, which of them cause more hypokalemia?
So loop diuretics has a stronger diuretic action. Okay. So there is no proven study, but always loop diuretics will have a stronger diuretic effect. So loop diuretics. Anyone else?
Can we use non-dihydropyridines in complete heart block?
Non-dihydropyridines. Non-dihydropyridines, yes, we can use. Dihydropyridines should be avoided, as I said, because they have a rebound sympathetic effect, and that will cause again increased oxygen requirement. Okay, next. So always remember that whenever you are going, what is written is always not given to the patient. So make sure that you are checking the indent box also of the patient. You make sure that you are checking the dosage. You are checking whether the combination is given. You are checking whether the drug is used or not. Right? Any other doubts?
Uh, Recently, they have shown that SGLT2 inhibitors are preferred in diabetic patients with cardiac complications.
Absolutely. SGLT2 में दो drug है. Dapagliflozin and empagliflozin. Okay, they have a mild diuretic action that has been shown to be superior, but the major side effect that we have seen in hospital patients is many of them come with UTI, yeast-related UTI. They are not advised properly to take plenty of fluid. So what they do, cardiac benefit effect क्या है, is it shows diuretic effect. Okay, that is why it is superior over other anti-diabetic drug in cardiac patients.
Yes, sir, that is my question exactly. Some cardiologists have asked me like whether we can prefer it even though the risk of UTI is
Absolutely,
higher.
absolutely. I hope you got your answer.
Yes, sir. Thank you.
No problem. So, any other question, guys? So, no. So I would like to end this now, and I would like to thank Dr. Dhar sir, Dr. Karthik sir for this opportunity given because I was able to share few of the most important points in this session, and I would like to thank Alvin for coordinating and supporting me for this live stream. Thank you all. I hope you guys learned a lot, and you guys were the most important point is to be vigilant enough. If you are vigilant enough with less knowledge also, you would be able to improvise therapy in patients, and the points that I told are just the added points that will help you in the improvising therapy. Thank you. Thank you. Bye.
Thank you so much, sir.